Good morning, everyone. Hello, I'm Susan Lapidus, and I'm the director of the Murray Gallanson San Diego Israel Initiative. The MGSDII is dedicated to bringing modern Israel studies to San Diego universities and our community. As we have just hit the one-year mark since the World Health Organization declared COVID-19 a pandemic, it's appropriate that we look at what we can learn from this catastrophe that has caused such extraordinary suffering. Today, there's hope on the horizon, especially from Israel, which is reporting with nearly half of Israelis fully vaccinated, coronavirus cases plummeting to new lows. Our guests today are Dr. Manfred Green from Israel and Dr. Eyal Oren from San Diego, two prominent public health experts. Dr. Manfred Green is director of the Masters in Public Health program and professor of epidemiology at the University of Haifa. He's also the founding director of the Israel Center for Disease Control and previously served as head of public health branch for the Israel Defense Force. Dr. Eyal Oren is the director of the School of Public Health at San Diego State University. He is an epidemiologist interested in behavioral aspects of infectious disease with an emphasis on respiratory health. He is particularly focused on multidisciplinary, community-engaged approaches to addressing population health disparities and collaborative work that is innovative and emphasizes new tools and technologies. To moderate our discussion, I'm very happy to introduce Charlene Seidle, Vice President of the Leichtag Foundation and very involved in the San Diego Jewish community COVID-19 response and emergency fund. So following the talk, we'll be reading questions from the audience. So you can begin writing your questions in the chat whenever you are ready. Charlene, I'm turning it over to you. Thank you.
Thanks, Susan. I'm really excited about our discussion today for a lot of reasons. I think one reason that I was reflecting on earlier is that, God, so much has happened in the last year, but I know I have gained like a new level of respect and admiration and just like gratitude for our public health experts who have guided us just incredibly well under the greatest of pressures during this last year. And I'm sure before that, but maybe we're a little hidden from me. So I just really want to first just start by expressing gratitude to both of you and to your colleagues kind of as ambassadors. Thank you. In terms of the questions, I think actually instead of pausing at the end to read questions, just submit them in the chat and I'll do my best to just incorporate them and synthesize them because I have a few pre-prepared questions, but would rather get to your burning questions. And so would love, we can do that earlier than just at the end. So a couple things just to start. I pulled out what I think are the fairly most recent statistics about Israel. And from what I read, and you can correct me if I'm wrong, Manfred, 5.1 million of about an eligible 6 million of 16 plus Israelis that are citizens that are 16 plus have now been vaccinated, 5.1 with at least one of the doses of Pfizer. So that's, a very, very high rate. That includes more than 90% of people that are 50 plus. And interestingly, there's been major upward momentum in some of the harder to reach populations that maybe were a little bit more wary, but particularly in the Arab community. And I've also spoken to some Arab Israeli friends on the ground who attest to this, who aren't always fans of what the government does, but who actually feel that the government has done a pretty good job in terms of public education in their community about the vaccine. And of course, like a large number of those who aren't vaccinated are children who aren't eligible. As you probably read, Israel has also instituted a green pass system so that in order to get into most, cultural institutions, restaurants, many, many public places, you need a certain app that maybe Manfred will tell us more about. And that declares you as a vaccinated person. And actually, like, we were reflecting on this a little bit earlier, but I spoke to an Israeli friend of mine very early this morning who reflected on her day the day before, and it just sounded like a dream. She went out for brunch with friends in this beautiful restaurant in a garden, and then she went to a movie, and then she went to like some other kind of a educational program, and then she went to a play. I just thought, wow, what kind of pre-pandemic world are you living in? So we hope that that's the future that we can all look forward to, or at least I do. And so I'll get now right to the questions. As I said, we have a few pre-prepared questions that I will start with, and then we'll engage whatever you want to hear about from the chat in the discussion. So starting with you, Manfred, as sort of our on-the-ground person in Israel, what do you think are one or two of the major ingredients that led to the real accelerated success of the Israeli vaccine rollout?
Thank you very much, Charlene, and thanks to Susan and to Eyal. And I think it's going to be a great discussion between us. So we'll try and make it also a little provocative and see what that
Perfect.
I think there are three things, and I'll be happy to hear Eyal commenting also on what I say. There are basically, I think, three factors that have influenced the way in which the vaccine rollout in Israel has been so fast and actually pretty much really effective. The one is basically the simple one. We have vaccine. If they didn't have access to vaccines, then nothing else matters. And that we have to give credit to the government and to the public health officials who were advising the government for taking out options on vaccines that we didn't know were actually going to be vaccines that would work. And in fact, maybe we're not talking about it too much, but we've actually bought more vaccines than we need. We've taken out options on other vaccines. And up to now, we've just used the Pfizer vaccine. So basically, we have a good supply of vaccine. We have basically enough to vaccinate the population, or we will have enough. The second one is that we have a health system that's very centralized. Everyone has health insurance. Everyone belongs to a health fund or a HMO. And it's very easy, in a sense, to control the health services. So that once you are on the list to be vaccinated, meaning you're in the group that's eligible, and we started primarily with over 60, and then we dropped it to over 50, and so on and so forth, you would simply get a notification that you are now eligible for a vaccine, and you can set your time and your place. And if that's okay, and they give you some options, and then you go and get vaccinated. And then everyone knows that you've been vaccinated. So it's actually a very simple process. And there are vaccination centers virtually everywhere, very close to where you live. So it's not really a problem to get to them. Although I might add that there have been subgroups, and we may want to come back to that. These are people who cannot leave their houses because they are, disabled and ill and so on. And that hasn't been handled as well as we would have liked to see, but it's getting into place. So, and then the third one is basically Israel has had to deal with security problems. And there are the good and bad side of that. I'm not sure that we plan ahead very well. But when something happens, we react very rapidly. So basically, the early planning may not have been ideal. But once we had to get into action, it actually mobilized, just about everyone in the country, so that a lot of groups were involved in this, including the military, by the way, who were involved also in helping with testing and tracing and also vaccination in some cases. So this is a very interesting kind of situation. So I guess these factors really made it this is a formula basically, which may not be applicable everywhere.
Eyal, do you have do you have any comments on that kind of observations?
Well, I would just say we've seen a little bit of the converse, and true in the US, where you have a fractured public health system, right? We don't have a centralization either at the federal level. States and local jurisdictions have a lot of autonomy in their decision making. And also the healthcare system itself, right, is not centralized in the same way, where you've got four major HMOs, for example. Here we have some HMOs. We have somewhat of a safety net system. We have, this very kind of fractured system. And that means also that as you're seeing even now with a rollout where it has been kind of getting into motion, lots of different ways to kind of get your vaccine, even if you're eligible. So I think that's one. And I think the other piece is just, I think to Manfred's point, it's been challenging for those people on the call and in general who are eligible to even figure out how to get vaccinated in many cases. And a lot of that is due to the systems we have in place. And so one thing that Israel did very well was this kind of pre-registration system and being able to then reach out to people, right, and say, hey, we have an appointment for you. Like this matching, which means that doses don't go to waste and people know when to show up. And we've seen that happen in some places in the US, in West Virginia and a couple different Minnesota, but not in California, for example. And so that's something, again, because of that system, that's where there's a lot of local autonomy. It's also created, we haven't always had a best practices where we've been learning quickly enough. I'll just say that.
Manfred, you mentioned that the like those that can't leave their homes it's harder to access. I know that I've read, and we probably all have, a lot about the harder to reach, like the populations, like ultra-Orthodox, or that might have some cultural barriers. Can you say a few words about like those challenges of access amidst all this success? What key challenges has there been in terms of access?
As I said, I think that, again, we would be talking in very positive terms about how the vaccine rollout occurred, but there were problems in the planning stage. I think that we learned a lot of lessons, I hope, and we're going to implement them in the future. So, in fact, if you asked me about whether we were prepared for this kind of pandemic, we weren't really that prepared. We were prepared in some respects. But in many respects, we didn't actually plan for this kind of pandemic. Maybe you can say that this was true universally, but the fact that there'd be a virus that would be spreading rapidly and there would be no vaccine and no treatment, and it was something that we didn't really have a good plan in place for that. And I think that the people, as though, for example, those who disabled, those that were not able to leave their homes, particularly when the vaccine became available, were not really planned for in the way that I think it should have been. And I think that's something that has to be done in the future. In addition, of course, the Pfizer vaccine in particular is not like a flu vaccine where you can just take one dose and take it to a house and vaccinate someone. It has to be kept at very low temperatures. And then when you open one package, you have to use them all at the same time or within a few hours. So it was a much more complicated process in that sense, more complicated than we were planning for. So I think this is something we need to deal with in the future.
What do you think was learned? And I'm going to ask Eyal the same question. Like, what are we learning in real time about education, messaging, effective, ways to communicate, maybe in a more positive, way to maybe those who are either find it harder to access or for whatever reason are a bit suspicious or maybe mistrusting of government or officials? What either one of you can, I'm curious what maybe Israel has already learned, but Eyal, you could also start because we have, goodness knows, the same challenges here.
Sure. And I'm happy to, there's a lot, I talk quite a lot about this, so I'll try to keep it brief. But first of all, I think we actually, in some ways, you'd think we have a perfect setup in the sense that you have this awful pandemic, again, nobody imagined this. And then you have these incredibly effective vaccines. We're very excited about these vaccines that offer, high levels of safety and protection that are now getting into the arms of people across the United States and across the globe, hopefully. And so given that it's, I can follow up more about like why there's this hesitancy, but you'd think that would be kind of a recipe for, people really wanting to, and especially hearing what's happening across the pond here in terms of life opening up again, people would be really excited to get vaccinated. And I will say, actually, San Diego is ahead of the curve, the US curve. At this point, we've got about, say, 25% of the eligible population that's gotten a single dose and about 14% 2 doses. That's a little bit ahead of what's happening in the US.
That's great.
And part of it is actually, we've had a very proactive county health department, our Health and Human Services Agency, I think has done a very good job, especially recently in rolling out websites and messaging. And I actually had a call a couple of days ago where I asked, kind of, what are you doing? And they said, well, we have about 1,500 spots across many radio stations, 8 or 10 radio stations. We have 500 TV spots across 11 TV channels. We actually, as a university, are contracting and working with the county and others in having people on the ground, often community health workers who are individuals who are culturally sensitive from different communities to bring the vaccination message to different communities. There are things like we have 211, which I think people are familiar with. There's a call center that is very involved in supporting kind of types of questions people may have on this kind of webinar as well. So a lot of organizations with dedicated staff that are helping now to schedule vaccination appointments and to help with messaging. So I'm actually very optimistic in that regard. And maybe I can speak more about why the hesitancy and so on in a little bit. So hopefully kind of getting at your question.
Thank you. There are a lot of
local efforts right now.
Oh, go. Manfred, can you comment on also now you're ahead of us, right? I got that feedback about the Arab, experience being better actually, or the rates being better because of some interventions or education. Maybe you can also contest that. That was more of an anecdotal comment to me. So can you just comment on what you think has been particularly effective in terms of these barriers in Israel?
I think that we, like everything, people wait to see what's going to happen, basically. So in the initial stages, not unsurprisingly, people were suspicious of a new vaccine or new vaccines. When we'd been persistently saying that vaccines take a long time to produce and to be tested and so on, and then suddenly we're actually saying we have a vaccine that's now effective and we're going to start using it. So it's difficult to get a message across that this, in fact, is a vaccine that's been tested appropriately and we've put huge resources into it and, so on and so forth. So I think that there were sectors of the public who were more suspicious of the process and maybe also were less aware of the way these processes actually take place and how these vaccines actually get to the market or get to the people ultimately. So what has happened, I think, is that in the Arab community, to some extent, when I say the Arab community, I have to say it's not, it's a very big generalization. So we could talk about Arabs in the villages. There could be Arabs living in Haifa and so on. So it's a different, but let's say.
You're also talking specifically about Arab citizens of Israel, just to
Arab citizens in Israel. Yeah.
We'll get to the other. Go ahead.
And so they may be exposed in the villages, particularly, and villages can be fairly large, 10, 20, 30,000 people. They're exposed to a lot of the foreign media. And the foreign media had a lot of false information. I mean, there were broadcasts there, for example, from Egypt. There was a regular broadcast from a physician in Egypt on prime time telling everyone that these vaccines were dangerous and that they shouldn't take them and so on. So this is very influential. It comes through in Arabic, so that it's easy to understand for them and so on. So we had to actually make sure that messages got through to the different subpopulations. And, this was a process. But I think that once there was evidence, more and more evidence that the vaccine firstly was safe, because, this is the interesting thing. People first want to know whether a vaccine's safe and then if it's effective, which I guess makes sense. But if you think about it, if you just give you an anecdote, in 2009, when we had the pandemic of influenza and there was a new influenza vaccine, people were very hesitant to take the new influenza vaccine, but very happy to take the older one, which had no effect basically, but they said they would prefer getting the old one, which was not suitable for the pandemic. There's this kind of paradoxical situation. So I think that's to a large extent being overcome. But we are encountering one problem right now. I don't know how big it is, but there are tens of thousands of people who took the first dose and didn't turn up for the second dose. Oh. And we are trying now to understand why this has been happening. So it could be a combination of factors. Sometimes it may be because they are cautious about side effects, or they just believe that one dose is adequate because they hear on the news that one dose gives you a good, 60% protection or something, and they feel, well, that's probably enough. So
is that trend particular? Sorry, is that trend particular to the subpopulations that are maybe we're more suspicious, or just across the board? You're saying
we don't. I don't know the breakdown at the moment. We're still looking into it, so I have no idea what the breakdown is. I would guess it's in younger people. That's my guess, because that's the population, and they just may have neglected coming for the second dose. But I don't know the reason. But there is shall we say, not a huge number, but a significant number who we are looking at right now.
Eyal, can you also just speak to this issue? You spoke a little bit about like promotores, and it seems to me, again, just from anecdotal, that like there were a lot of language barriers. I mean, some of those websites just weren't even translated, say, into Spanish, or and let alone how do you see this issue and the more encouraging trends also?
Yeah, I think so. I think towards the issue, I think there are quite a lot of factors at play. I think for one, you have a history in this country that's actually, people think it's recent, but actually it goes way back, with vaccine mistrust. People holding strongly held political, cultural, religious beliefs, and on these topics range. They can oppose public health mandates, kind of government control, to vaccines in general, to, again, vaccines causing disease. So I think that's one piece that's kind of broadly out there. You're hearing, I mean, it happened just north of us in LA. You may remember even it hit like the front pages of the LA Times, people kind of marching and blocking access almost to a vaccination site, maybe a month and 2 months ago, maybe. But then beyond that, you also have much broader issues. And those are, in San Diego, it's getting better, but we've still seen that different groups, and minority groups particularly, are getting disproportionately small amounts of available vaccines. And that has to do, again, with a number of factors. And some of those are indeed language barriers, cultural mistrust of the government, of vaccines I spoke to, some issues that are often historical and present today around systemic racism in the healthcare system. More broadly, we're in this political spectrum right now, right? In the last 9 months, we've seen a lot of broader discussion about racism. Technology access, I can speak to that more broadly too. And then even lack of vaccination sites in well-placed areas. The most highly vaccinated earlier on in San Diego were also the most affluent communities in San Diego. And then it's probably this mix of things, again, having access to sites, knowing where to find information, things like that. So a lot of it is about, making sure information's out there in multiple languages, having the sites in easy to access community venues, churches, synagogues, schools, whatever it is, engaging leaders of different communities to be the messengers. So they're trusted messengers, right? And this gets complicated for certain populations also, where we don't even know truly what's going on. And so there was an interesting article that actually was in our Union Tribune locally about how individuals in the Filipino community were not getting access. And it was partly because the way the county lumped Filipinos into an Asian category. And so it sort of looked like, Asians were getting vaccinated, but then what about individuals who are Filipinos? So I think there are a lot of those issues, and we've seen really big disparities in vaccination rates across the county. Part of that is because of just depending on who's eligible in terms of healthcare worker and so on, but more broadly, again, around access and some of these things that I just mentioned.
There's a couple questions coming up that now that we're on this, and people have questions also, I think, about like particulars about are they immune or not. We'll get to those towards the end, whether or not you'll be able to comment, we'll see. But there are a couple questions while we're on this subject about the technology barriers and technology in general. And just asking that maybe, Manfred, you could just drill down a little more on what the exact kind of a technology process was, or like how people found out about, the vaccine from a technology perspective. And also any additional comment on technology barriers that you see for us here in San Diego, or just technology tools. Maybe you could just tell us specifically what that process looked like from a technology perspective in Israel, Manfred.
Could you, you're talking about the technology in actually producing the vaccine?
No. Oh, I'm sorry. In accessing the vaccine. Like my understanding is some of this was through like WhatsApp groups or, like even on that level of detail you could share.
Well, Israel is very much into the digital age. So your access to your healthcare is very much through the internet and through or your smartphone or whatever. So you're very much connected to your healthcare supplier through that, and you get messages. So it's actually quite easy for them to basically get messages through to you, and they'll get it to you generally, I guess, through your smartphone. In other words, you'll see it on your smartphone or on the internet. Otherwise, there may be, sort of more active types of intervention. But basically, Israelis are very strong users of the health system. So they use, I don't know how many times a year. So it's a very much heavily used system. So most people have a very, shall we say, close relationship with the healthcare supplier. So, and that makes it also, it helps the communication as well. So, and of course, through the media, this is all the time on the media, how to get in touch, how to do it, where do you go, where do you get the information from, and so on. So the information, where there may have been problems, and probably were, and we did have that, let's say that, let me give you it sounds like a kind of a sort of a semi-classical kind of example, but an elderly Arab woman living in a village who has not really been accustomed to using the internet and so on, and also doesn't move much out of the home because she doesn't have transport and so on, and she's dependent on family members. So that may be a barrier, basically, and I think that was a barrier initially, the lack of understanding of where to go and how to get access to the vaccine. So in those subpopulations, some of that, the lower vaccination rates in that population may have been due to that. But in addition, and I add that again, the misinformation that came out, I'm sorry that I'm just going back, and I'll just mention it again. The anti-vaccination people, who, whatever their motives are, have been using this concept of the vaccine affecting fertility. But this is not something new. This is an old kind of trick. And why is it so commonly used? And we haven't basically probably counteracted it enough. Because if you think about it, it's very difficult to counter the argument. I mean, you can't prove that the vaccine does not cause infertility. All you can say is that it's biologically not feasible. And it's a long-term effect. So people will say, well, we haven't seen it now, but we'll see it in 2 years' time. So and it's been used in Africa, it's been used in all over the world to try and interfere with vaccinations. So we need to be much more sophisticated in dealing with the so-called more sophisticated anti-vaccination groups. And this was very strong initially in the Arab community. And so you heard this repeated over and over again. Do you really know that it doesn't affect fertility? Well, obviously it's a answer that you can't really answer very easily. All you can say basically is there's no evidence that it has, and there's no biological basis for that. So this is something that's more difficult to explain. It's not something where you would say, have there been more fatalities with the vaccine, or has it caused other kinds of injury? That's things that you can see. You put something into a kind of a invisible effect, and that's very effective in many respects. So we need to look for ways of dealing with that.
Absolutely, and there's a lot we can learn also from that for the in general, if we have the will politically and communally to learn it. Yeah, like in terms of the technology, what we heard from you, Manfred, is mainly it's the close relationship that the healthcare providers or healthcare HMOs have with their constituents. And I mean, my impression is also the smartphone and its widespread use in Israel, because that was how a lot of this, any comments or about just technology in particular?
Yeah, I can say quite a lot. I'd say, again, it goes back to the fragmentation of our system. It's very difficult for me to comment on a national basis. It's almost impossible because it's just completely different everywhere. Yeah. But even in California, what we've seen up to now, for the most part, has been web-based appointment making. So it's not preemptive, like we talked, it's not pre-registration, and basically means that people have to be savvy enough to first go to the appointment. And then it's almost like getting a concert ticket. You keep having to refresh. So if you're a 20-year-old and you're used to this, maybe it's one thing. But if you're 85-year-old and this is not what you're used to doing and you're trying to find that appointment, it's quite challenging. And not only that, but there have been a lot of cases where people have been able to get a first appointment, but not a second for a second dose. They're sent to someplace remote to get their appointment. I mean, all kinds of interesting snafus. And even more complicated has been the fact that we've had, because of the fragmentation, different counties in California have had different rules. We know this is across states. So you probably heard, your cousin in X state or whatever, or maybe it's X county is getting vaccinated, but you're not. And so what we've seen in California is that some counties vaccinated people who are 75 and over, others set the threshold at 65. And some rural counties very quickly vaccinated priority groups and vaccinated teachers and other essential workers, and larger urban counties focused on higher risk seniors. So really that also makes things very confusing. And we've even seen people changing tiers. We've seen even the rules of the game kind of shift over time, largely because of the supply, right? Like how that supply comes and goes. So really complicated. And now we have in California and in San Diego too, this My Turn website that's even administered through a third party, through Blue Shield. And again, there's optimism because it's sort of a central process. It's supposed to simplify things, but it excludes a lot of the pharmacy-based vaccination sites. It excludes Kaiser as a large HMO. It's not, so there's still a lot of complications in terms of that. And then on top of that, you actually have a lot of local community groups in San Diego who are actively working with different populations. And right now, these systems don't really interface. And the question is, are these groups going to be asked to also use My Turn because it's a central way of doing things when they have systems that work for them? So I have a lot of thoughts about this, as you can tell. And I think it's very challenging. With all due respect, it's really, they're trying to also put together a lot of databases in terms of where the supply chain, where things are, where the sites are, the immunization registry, all these different things. But unfortunately, I think it's made it for a very complicated system for most people.
Definitely complicated. In a minute, I think, or in a few minutes, we'll get to the I know some of the kind of burning questions that are coming in about specifics of transmission. But I do want to get to a broader question where there is, I think, a lot of interesting comparability between San Diego and Israel. And it might be one of the more provocative points that you were referring to, Manfred, which is always interesting, which I think is this issue about borders. Like, we know that viruses don't really have borders. It's been somewhat frustrating for me, to be honest, personally, to hear how some of these nuances reported here in the States about Israel. There's lack of nuance between Arab citizens of Israel, Palestinians, and, which areas. Of course, there's a lot of nuance, but the broad question is, or the broad message is, that viruses, they travel through borders. I mean, so can you comment, maybe starting with you, Manfred, and then going to you, Eyal, about some of the discussion in the media, particularly if you've been tuned into the foreign media and media here, about the critique and criticism that there has been fairly strong, I would say, about Israel's lack of will, according to some of these messages, to share the vaccine with their Palestinian neighbors in Palestinian territories in the West Bank and Gaza, and what you think is like fair critique and what you think is not that fair critique. And then I'd love to hear from you, Eyal, because I think we've been hearing some of the same things in terms of our border with Mexico that, of course, is right in our backyard. So, Manfred?
Okay, I'll actually come out right up front, as they say, and say what I think. And I know that's often what's quoted, so maybe that'll be controversial. But I do believe that Israel has a responsibility for the health of the Palestinian population in the territories, particularly for infectious diseases, as you say, which know no borders. And I believe that we really do have a responsibility to make sure that that population is vaccinated. So that is my view, and I think that should be part of the policy of the government. And that's because of several reasons. There is obviously the humanitarian one. There's a pseudo-political one because the Palestinian Authority is not entirely independent and is dependent to a large extent on many aspects of Israel, of the Israeli government, of the Israeli authorities. And the other, of course, is that if the Palestinians are not vaccinated, then we're not safe. So, we can kind of make, whatever argument you make, whichever side of the political fence you are, it makes sense to make sure that the Palestinians are vaccinated. I would like to believe that we also have a motivation. That is that these are our neighbors, and hopefully at some stage they'll be our good friends. And we must make sure that they are getting the same kind of services as we are getting, and that they certainly should be vaccinated. And in the past, we've collaborated very well on vaccines, by the way, for polio and measles and so on. So it's not something new. And recently, there maybe have been a little bit less collaboration on these, but in general, we report to one another, and at a professional level, we're in touch with one another. So that should be done. And so I'm saying that up front. Let's go now to the more sensitive area. What happens when we meet a situation like we're in now, where we may, at least in the initial stages, you're not sure that you will have enough vaccine supplies for your so-called own population. And and I know that this is a very broad issue that the WHO is, trying to deal with, the so-called vaccine nationalism. But, I'll quote something. I heard an interesting thing, and I quoted, maybe I'm misquoting, but I heard Tony Blair, the former Prime Minister of the UK, some time ago, when they asked him about the UK helping other countries to get vaccines. And he said they should definitely do so as soon as they have enough for their own population. So he added that other sentence. He said, when we've actually vaccinated our own population, then we should start helping others. That was the kind of the message, which was kind of strange, I thought, because that, there's a kind of mixed message. But it's a very natural one. So you can argue that for the Israeli government or the population to say, first, let's give some of the vaccines to the Palestinian population and not give to some people in Israel who are still waiting, that's a real issue. I mean, it's a human issue and it's a political issue, whatever you like. So I think that the compromise in the middle is at the same time as you're vaccinating your own population, you are making strong efforts to make sure that the Palestinians have access to vaccines. In other words, we should be helping them to negotiate to get vaccines. We should help them financially, and we should help them to make sure that they know how to actually administer the vaccines, because we have a lot of experience. So in other words, we should be partners in this. And I think that can be done. And I think that the Palestinians, by the way, were expecting not more, weren't expecting just to get the supplies from Israel, but to actually get support. That's my impression at any rate. And I think even whether or not it is, I think that's the way I think it should be done.
That's really helpful context. Thank you, Manfred. Eyal, can you comment on our situation?
Sure, yeah. I largely agree with Manfred's thoughts in this regard. I will just add two other elements that I think are also interesting to think about, given that we live close to or on a border, in a border community with Mexico. The first is diplomatic. I think Manfred touched on that, but you've seen many countries engaged in what I call COVID diplomacy, whether it's vaccines or face masks or whatever it is. China has been at the forefront of this, a number of countries. And I think it goes a long way for those countries in terms of goodwill. I mean, Israel's done this a lot with emergencies, right? It's what they've jumped in. So I do think that's something that's important to think about. The other is really economic. And I don't know the scale of it, but I can tell you on the San Diego and Mexico and Baja border, we've got a multi-billion-dollar economy, cross-border economy. So if you think about it from that perspective, you want to be able to vaccinate on both sides of the border quickly enough and at the same pace in some ways to allow for those economies to continue to function and this mass movement of people to continue to happen. And I think to some degree that's also the reality in Israel, right, where you're talking about a lot of people crossing over for jobs, and how do you you prioritize only those people who cross X times a week? I mean, I think it becomes kind of both morally and ethically kind of difficult to justify. So I think I think those are things to think about. And I will say that the US also has a surplus. I don't know if people are aware. At this point, the US also has a large surplus of vaccinations, believe it or not, even though I gave you the stats earlier and we're not anywhere near getting everybody vaccinated yet. So there really is, I think, a discussion to be had about what that looks like. I mean, sort of these concerns of like, do we have enough? Do we really have enough? Are we going to do this? Versus having that supply in check. I will say this, in Mexico right now, just thinking about the cross-border, I gave you the stats in San Diego earlier. You're talking about 3% who've gotten a dose and about 0.5% who've gotten 2 doses who are fully vaccinated. So they're abysmally low numbers. And that's, to me, is really something that's not been picked up enough in the media. If you try to start Googling this, and I don't see that much discussion. We talk about our immediate neighbors to the south, the state of Baja California in Mexico. They've only gotten about 40% of their promised supply from the Mexican government, and that's not enough to even cover all the healthcare workers in the state. So what's happened is a decentralization in Mexico, where their states are now allowed to negotiate to purchase their own vaccines. So again, that's great. There's empowerment, but that's very difficult and means, again, there are a lot of inequities in how that's happening. And so I think, I don't know what to say about that in terms of that immediate support, from San Diego community, but I know that there have been a lot of vocal voices actually from local politicians, especially close to our border on the US side, who basically expressed concern over the continued devastation to the economy, really, from an economic perspective. And so I would just kind of talk to that as something we should be thinking about, what that means for us.
Thank you. Going to a few of the questions that are coming in. First, just looking at kind of the broader questions, and then I promise we will get to these questions about specifics of transmission. But first, just I think, Eyal, for you, while you have the floor, there was a question that came in terms of like the anti-vaccination discussion and asking if any specific comments about the Catholic Church's sort of criticism or about those vaccines, which I'll let you explain, but I think that they use embryonic matter. And if you have any thoughts about that or reflections, I assume it's not such a big deal. That one isn't in Israel, Manfred, but maybe I'm wrong. You don't have a big Catholic population.
No, it hasn't. Well, it could be an issue if it was related to abortion, but it hasn't been we have another issue, whether pork products or so on are used, because there is sometimes occasionally that's used in some matter. It's not used in any of these vaccines.
Oh, Susan, you're not on mute. Eyal, do you want to address that? You are on mute. Yeah.
Sorry. Well, first of all, the COVID-19 vaccines do not contain any aborted fetal cells. That's just completely made up. Where I think there's some confusion is that Pfizer and Moderna to ensure the vaccines work, they do use what are called fetal cell lines to confirm the test. These are essentially cell lines that are used in the vaccine development, but this is not fetal tissue. These are cells that are grown in a laboratory. They come from cells that were taken from abortions 50 years ago, and they're individual cell lines that just keep in the laboratory, one can keep multiplying them. So there are thousands of generations removed from any original fetal tissue. They don't contain any tissue from a fetus. So I just want to clarify that, but that's something that is very commonly done in vaccination technology. It's a source of figuring out, is this going to potentially work in humans? So I just want to address that and talk to that further if needed. But
I probably didn't state it correctly. Oh, yeah. I apologize.
I'm sorry.
I think the question was more about messaging, like what kinds of, you described some of the ways that the educational tools for some of the other, fertility or are there specific messages that you're using in the public health community to counteract this maybe misconception?
That one in particular is so I will say what's challenging is, I just gave you more of a science-based rebuttal or logic-based rebuttal, and that often does not work. And so, so I think you have to understand what values people have and where they're coming from, what underlies this kind of argument. And, is again based on a particular religious principle or or cultural principle in some cases, and understand, really come at it from that perspective. I will say there are definitely a lot of things to think about in terms of just countering misinformation more broadly, in terms of appealing to, like with vaccination, it's about protecting not just you, it's about your community. At this point, it's about some of the immediate losses we've had if we don't vaccinate. So, 1 in 3 Americans, I saw an article on Axios, I think the other day, it basically knows somebody who's died at this point, which is crazy. And so, it's some of those, the personal stories and understanding the impacts of this pandemic. But, I think with regards to these particular pieces, I think often it's trying to counter with the specific, where we do have the evidence and where there are just evidence gaps. But I think also appealing more broadly to look why this is so important. This is the technology we have to make vaccines. This is the approach that we think currently is viable, and so we have to. And vaccines are really such an important tool, right? They're such an important tool. Without them, we are stuck in this world of, it looks like politics in the U.S. of like, do you wear a mask in the store? Do you not? Do you distance? Do you not? And so that can all be taken off the table in theory, again, if you're able to get to a point where there's negligible transmission of this virus. So maybe at that point, now I can talk more about very specific communication messaging, but I think maybe that's what you're getting at.
Yeah, that's great. Manfred, a couple questions about Israel. A couple questions came in about the specific deal with Pfizer and Israel. And there was also a carry on about whether or not that influenced some of the travel restrictions or any of, let's just say, broaden it to any of the policies that the government may have set in motion. Can you just speak for a minute about that deal? People seem interested to know more.
I have to make it clear that I'm not sure that I know all the details of the deal. There was a document released which didn't have all the details in it, but it had a lot of the details. But basically, I think in some senses it was the public relations for that deal was handled pretty badly, because initially it was almost kept as a secret and it couldn't be disclosed and so on. And a lot of the stuff that was ultimately disclosed could have been disclosed right from the beginning without any problems. So it became an issue because it seemed like there was something suspicious about the deal. I think pretty much what I would understand is that Pfizer did not want other companies and so on, others to know, or other countries to know what were the conditions of the deal, I guess the financial aspects and what kind of benefits Pfizer would get out of it other than the financial aspects. And the main one was basically to monitor the disease rates after the use of the vaccine. In other words, follow the use of the vaccine in the field. In a sense, it seemed to me that they didn't really need to put it into a deal because we would have done it anyway. So, but I guess it became an issue and people then became suspicious. I don't know of anyone who has actual ties with Pfizer, certainly financial ties that were involved in that deal anyway. So it was not a question here of personal interest. It was simply, I think, a question of Pfizer getting the rights to see the data from their vaccine before others saw it, something like that. But ultimately, that data is available now, so it's freely available. So there's nothing really hidden right now, as far as I know.
Thank you. So a couple of questions about specifics of transmission and what can people do, with, I guess, the caveat that, you know what you know as of today, and things are changing rapidly. So feel free to say that. But there's a couple of questions came in about the ability of fully vaccinated people who follow, who kind of followed the rules, about how long to wait. Can they transmit the virus, particular to children and young adults? Who wants to take that? Or Eyal?
Well, you want to start? Eyal?
I can start, and then you may have your finger on the pulse, which is the data from Israel. But I'll say this, maybe 3 pieces. The first, there's been very strong data coming from Israel because of this data sharing agreement with Pfizer. So you've got this population-based information that's come through. That one, you have great protection from symptomatic infection. So probably from infection more broadly, and 2 from severe disease, right? So really, and we've seen that reduction in ICUs and hospitalizations, and we're, so to a great degree. I just saw some stats from Israel about how the infections are really moving along to younger people who probably have not gotten vaccinated. And so the second piece is really that with some of these behavioral measures. So I think the question I saw in the chat was really, well, if you're fully masked, if you're distanced, if you're following other precautions, you really add on a lot of layers of safety, right? In terms of being able to transmit disease. If both people are masked, you're following distancing and so on. That said, there is no direct data that I know of that really gets at transmission yet, especially not between, vaccinated to unvaccinated. And you can imagine that's a complicated thing to either design as a study or think through. And I think we're in the process of where we'll have that information. But because of that, in the United States, the Centers for Disease Control, the CDC, has not issued kind of formal guidance around that. They've been very cautious about it. And because of that, it's also a difficult thing to answer in terms of, well, you can or cannot. We presume that that risk is much reduced and much reduced with someone who's vaccinated and now is taking precautionary measures, right, around their unvaccinated grandkids, for example, or so on. I think I'm really, not here to be on a high horse or anything like that to tell people, well, do this or don't do that. Now you're vaccinated. You want to see your grandkids. You heard Fauci saying he was going to visit with his grandkids, and I don't think he got into the details of what the interactions would look like. So, I mean, I think there is, unfortunately, I guess, some level of individual level sort of risk assessment that needs to happen as well in terms of knowing what your tolerance is, other tolerance, having that discussion. And we've kind of been dealing with that all along in the pandemic. But just kind of in terms of where we are with the kind of the known evidence base, that's, I guess I just wanted to sort of speak to that. And Manfred, you may be able to add to that too, in terms of whether there's more that's been coming out from Israel.
Yeah, and Manfred, certainly about that. And then maybe there's also some questions about the variants. So maybe you and then Eyal could also just throw in kind of your thoughts about, or what the current thinking is about whether the vaccines protect against the variants.
Yeah, I think Eyal has explained it very well. And the only thing I can add is that if you think about it logically, what are we talking? We're talking about a situation where someone who is vaccinated then comes into contact with someone who is ill, who has the virus, and contracts the virus but doesn't get sick. In other words, it actually gets transmitted, and then it's actually into the person who's been vaccinated. And then you have to take it further and say the virus then is going to replicate, in other words, reproduce itself in that person without causing illness. So first of all, someone who's vaccinated, generally speaking, or who's going to get asymptomatic infection, because that's pretty much all we've seen at the most in the, not only, but I mean, largely, would mean that their viral load is pretty low. They're probably not excreting much virus anyway, even if they do get infected. The analogies that sometimes have been used are for polio, for example. With polio, you can be vaccinated using the inactivated polio vaccine, and you can then get infected with the virus, excrete the virus, but you don't actually get sick because it actually does replicate in the gut, but it doesn't get into your bloodstream and it doesn't cause any illness. So basically, or gets into the bloodstream, but it gets neutralized. So basically, but that's an enterovirus. In other words, it's transmitted by food or contaminated stuff. So basically, this is a respiratory virus, and it does seem a little unlikely that you would be colonizing. In other words, keeping it, and then it would be replicating without you actually, even though you've vaccinated. You may want to compare it with meningococcal disease and so on, but in those diseases also, we don't really see much transmission from people who are vaccinated. On the other hand, we are still very cautious because it's a new virus in that sense, and it's a new vaccine and so on. So I think that with caution, particularly at this stage, I would also recommend still using masking whenever possible, when in fact you're in very close contact, certainly with people who are not vaccinated. And we need to keep some social distancing in place for a while, just to make sure that we don't, miss something and then get an outbreak again. So or at least lose control. So I think that we're really saying out of caution that until we really have much more hard data, we would like people to really be much more cautious than they would be under normal circumstances. And I don't think, I think the restrictions are fairly simple. And, they're wearing masks and basically some social distancing, which is just, not too, in Israel, I think it would be a good thing anyway, because people, if you ever stood in a line in Israel, you probably feel that there should be much more social distancing generally, because people tend to maybe push and crowd you. So maybe a good thing for the society generally.
And so would you say this similarly about the variants, that because kind of the data it's still early days?
The variants are another story.
Okay.
As long as the virus circulates, and it's an RNA virus, which is a virus that does tend to change. It does, it replicates and makes mistakes basically, and then changes, and then creates basically proteins, the antigens, which actually may not then be recognized by the antibodies that you produce from your vaccine. At the moment, it seems that most of them are recognized, at least to a large extent, although, as you've heard from the South African variant, there was at least the AstraZeneca vaccine, did not seem to be very effective in recognizing that virus. So we have to be up to date. But I'll make one very quick comment. If you would have thought of where we would be in this pandemic 5 or 10 years ago with the technology we had then, we would have been in a different place. We would have seen a huge increase in cases and deaths and so on and so forth. The fact that we were managed to get vaccines so rapidly and such effective vaccines is great. It's technology, and I guess in a way it's luck that it happened now and not 5 or 10 years ago, because the technology only really came into place fairly recently. And the vaccines like the Moderna and Pfizer and so on, the mRNA vaccines particularly, are fairly apparently, I mean, that's what they tell us, but the technology seems appropriate. They can make changes fairly rapidly. So in a fairly short time, they can produce new vaccine. It's not like the flu vaccine where it takes you months to grow the new vaccine and so on, which is a long process and uses a lot of eggs or whatever process you use. So in fact, if there is a new variant now that is not going to be recognized by the antibody, then there'll be new vaccines coming out. And in any event, I believe, and I guess many of us, not just me, that we'll be giving booster vaccine doses anyway. So I would say we need to get ready for the third dose anyway. And it's not, by the way, I don't think people should be worried about it. Lots of vaccines we give 3 doses. I mean, in kids, sometimes we give 6 doses. So it's not unusual to give repeated doses of vaccine. And this is an inactivated or not live vaccine. So this is not unusual. So this is, I think, the way we'll deal with the variants. We don't have to, I'm going to say a terrible thing, but don't quote me. I don't think that we have to be terrified of these variants. I really don't think it should be this terrifying specter in the future. I think that we'll deal with it, but we have to be very careful and keep watching out for it.
I know that there were some questions that we didn't get to, and maybe Mitch, if you're listening, we'll do like a screenshot or whatever of the chat, and we can follow up individually by email with Eyal and Manfred, who've been so generous. Before turning it over to Susan to do a close, I want to ask each of you to do kind of the impossible thing, which is like in a minute, can you, what is one thing that you think is the most important thing that the world should be doing now or in the near term to prepare for that the next virus or the next pandemic isn't so deadly? Because we certainly know that there will be a next one. And so what is the 1 or 2 things that, are just the most important? Who wants to start that impossible question? Eyal?
I don't. Most is a lot of pressure, but I will say this: our country, I'll speak for the United States for a minute, has been neglecting public health infrastructure and investment in pandemic response for a very long time. In fact, there was some defunding of some of these kind of early warning networks and so on earlier in the former administration. So one thing that I'm very optimistic that I'm seeing are a number of different bills that are promising to reinvest, and they include, Biden's bill, but they include some others. What's her name? Sorry, Patty Murray from Washington introduced a public health infrastructure act that would allow for core public health infrastructure programs to strengthen the public health system as a whole. We've lost, people are underpaid, there are not enough people in positions. I mean, there are all kinds of things around many capabilities. And there's another Lift America Act that was introduced in the House of Representatives, also around public health infrastructure. So a number of these initiatives, I think, are really essential to just get us to a place where there's workforce, testing capacity. I mean, if you talk about the strains, for example, we got most of our strain data from the UK because they were actually doing the needed, had the needed resources to look and understand what each strain looked like, essentially, this whole genome sequencing. We didn't do this wholesale. We're still not in the United States. We haven't had the capacity, which is crazy for a country as wealthy and well-resourced as we are. So I think, to me, those are really critical. And I hope, again, depends on those investments that countries, that the World Health Organization, these broader entities put in. But I think those are essential to be better prepared. So I'll at least say that.
Thank you. Manfred?
Yeah, I guess I'm going to say things similar to Eyal, but I would repeat, I think, a little of what I'd said, and that is that we have to recognize, at least I hope that we'll recognize, that the people who should be leading the planning and also the control of pandemics should be largely public health people who have been trained in public health. And this didn't necessarily occur in this pandemic. And I think that's partly due to the fact that we haven't trained enough people, particularly in infectious disease epidemiology. And I'm sure that Eyal knows that has not been a popular branch partly because of a lack of funding. And I'll just tell you a very quick curiosity. I've been working previously and still to some extent on bioterrorism preparedness. And I published a paper on bioterrorism preparedness, and one of my colleagues, in one of his kinder moments, said to me, "Who's going to read that? Nobody's interested in that anymore. There's no bioterrorism." And it was a little difficult for me to try and explain to him that bioterrorism preparedness is preparedness for pandemics. It's preparedness for epidemics. It's preparedness it's public health preparedness. And I think that this is something I know that I'm repeating because that's so important. And, I don't want to comment on the US, you would know better, but I sense that the CDC was not given an appropriate role in this pandemic. That's my feeling. But in Israel, it was also bypassed. To a large extent, the public health community were not in the forefront as I believe they should have been. They did their job and they did work, but they were not, it's certainly initially regarded as, there were committees set up to handle the pandemic, which did not have one epidemiologist on that committee, which was kind of odd. And I think that's something, it's a failure of our system, but I guess it's our failure as well. Maybe we just didn't train the people to be in these positions at the right time. And again, you have to put money into things that might happen. It's not always, that's what you need to do. You can't keep saying we'll wait until the moment and then we'll start invest. This takes years and years to prepare for. And I hope that this will be given the prominence that it should in the future. So this is planning.
No.
This is basically public health preparedness at all levels.
Thank you, Manfred, and thank you, Eyal. This has been a spectacular discussion. We can't thank you enough for your time and just leadership and hard work. And Susan, I'll turn it over to you to close us.
Thank you, Charlene. I just want to add my thanks to that such brilliant public health leaders from San Diego State University and University of Haifa have given us an hour of their time and the planning. So we can't thank you enough. We hope that this relationship continues with us and with each other. And we'd like to, there's lots more questions. It's been spectacular. Stay tuned for part 2, maybe part 3 in the future. And to the audience, check our website and look for your e-blast. We have more events coming the end of March and April, and thank you for your great support. Thank you, Eyal and Manfred, really, so appreciated.
Thank you. Thank you. Well, thank you, Eyal, and thanks to Susan and to Charlene. It was great.
Thank you. See you in Israel.